My name is Dr. Andrew Prynne. I am a general dental practitioner on the south coast of the UK. I have been there for 35 years. I have got the privilege of age, so I have with time focused on things I enjoy doing in dentistry. So implant surgery, cosmetic work, CAD/CAM restorations. I am lucky enough to live on the south coast of the UK. To the left of this image here is, across that watery bit, is France. And to the right, just the other side of these people, is the office that I was in for 35 years. And I was actually in this office for 60 years. Now that seems like a very young dentist when I started, but in fact, I was actually a little toddler walking in as a patient to this very office when I was young. So I've been there all my life, and it has been a very important part of my world. I am here tonight to talk to you about something which in 2014 completely changed my practice. It changed my enjoyment of practice, and it changed the experience I had for my patients. It changed the experience of my business, and it was so powerful. I have spent the last 12 odd years talking about it. And I'd like to talk to you about it as well tonight. So let's start with an abstract. It's a concept that I'm sure many of you will totally understand, and that is that we as dentists cannot work without anesthesia. Anesthesia is a core part of what we do. It actually allows us to form a relationship with our patients. Without anesthesia, I think I would be right in saying our relationship with the patients would be a terrible one, given everything we have to do. Equipment in dentistry, certainly since I started, has evolved absolutely out of this world. So, for example, for the restorative drills, it started off as a cable-driven treadle. We got the air turbine. We then went on to electric speed-increasing handpieces. And of course, now we have lasers. I mean, it's been astronomical, the evolution of that. The analog wax-ups that have been done by very skillful technicians over the years is now all digital and computerized in the smile design. How many impressions have I taken in my career? But impressions now were completely replaced by scanners. The X-ray kit that we use, which was one day freestanding and it was sending X-rays in every single direction, it then evolved into this slim wall-mounted X-ray units we know now today with the collimation, and now that has evolved further to the use of Star Trek-like hand devices and three-dimensional CBCT machines. Evolution is absolutely terrific. Dentures, which I would have made many thousands of in my career, are now replaced with implants. So this has been a terrific growth in the dental industry. The syringe that I might have used in the 19th century, quite extraordinarily, we're still using. It really hasn't changed very much at all. Tonight, I'd like to talk about that in great detail. You may ask me, what's wrong with that? This syringe, it works perfectly well, and it does, don't get me wrong. But if any of you have heard me speak before, you'll know that there is a dark side to traditional techniques, and I'd like to just focus on that for a moment. We have got a good understanding of the disadvantages of traditional techniques, but dentists as well as patients have just accepted that. We've accepted all of these problems. Not for long, I would like to hope. The problems can be seen as those associated with the patient and those associated with the dentist. For the patient, there is an inbuilt fear of anything sharp and pointy, and I think we can all align ourselves with that. Pain and anxiety during treatment, this has a very intense relationship with fear and pain. So if someone arrives at your practice who is frightened, anxiety is high, their sensitivity to pain will be vastly exaggerated. Any little feeling is that they're going to feel. And if they experience pain, that's going to have a negative feedback back to fear. So it's a vicious circle. And what our job is here is to break that cycle. If we can break that cycle, all of this goes away. And this is something that I have experienced over the last 10, 12 years. Inconsistent or incomplete anesthesia. Now this happens, failures of anesthesia, especially when it comes to blocks. Multiple injections may then be needed to do that. Now let's focus on what our nemesis is in dentistry. I would think you may well agree with me that our nemesis is probably the hot mandibular molar. It's a difficult one to deal with. And what supplies that with a nervous system? That is the inferior alveolar nerve. Sadly, the inferior alveolar nerve block is the most common failure in dentistry. And it's not because you as doctors are missing. You're not sticking that needle somewhere where it shouldn't be. There are reasons, good reasons, why these fail. A lot of studies have been done, and they've shown that the inferior alveolar nerve definitely supplies that tooth with nervous stimulation, but also through accessory canals, all of these nerves can innervate teeth. So all of these nerves are capable of making that tooth feel pain. It would be lovely, wouldn't it, if the complex neural anatomy was like a domestic consumer unit. We might be able to just unscrew one wire, remove it, and that circuit would be dead. Not the case with the human being. In the human being, we have got all of these other nerves supplying those teeth through accessory canals and nutrient canals in the mandible. So the literature shows very clearly 15 to 20% on average of failures of inferior blocks, and the studies are numerous. The best study that I would like to show you is one by Professor Johan Apps, he did a retrospective study on 3D scans, and he demonstrated very clearly that 95% of us humans have at least one accessory canal, which can bring with it fibers from these other nerves to innervate the teeth. So you have given the very best inferior alveolar nerve block possible. If you dissected out the inferior alveolar nerve and poked it with a sharp instrument, the patient would feel nothing. Yet you get to the bottom of the restoration that you're removing and replacing, touch the dentine, and the patient jumps. My goodness, why? Professor Apps showed that out of those 95% of humans that have at least one accessory canal, they can have up to 11. And that image there shows one slice in one of his patients where there are 5 canals in one slice, any one of which can be bringing nervous innervation. He concluded at the end of that study that neurovascular bundles that do not originate from the mandibular nerve can and will only be anesthetized if you place anesthetic solution directly in the bone, around where any of those fibers are. So this is real, and it's not our fault. Multiple visits to the doctor is something that for mandibular treatments, we don't do bilateral mandibular blocks. And then, of course, you've got the collateral numbness. This is a big problem for patients. That means that they are functionally compromised. They can't return to work. They can't return to school. And this chewing of the lip is something that is not just exclusive to children. I've known adults who have gone away and done this. But quite extraordinarily, we are also causing a lot of trouble to our adult patients in the form of the loss of motor function, the droopy lips, the inability to speak, eat, drink. It is real, and we're doing this to our patients. So for the dentist, one of the most important things, I think, in our business world would be time management. We're waiting a lot of time for these anesthesias to take effect. And this is a very costly experience. And I'm going to just show you a spreadsheet that we have and we are able to provide for you. It is marked up here in dollars, as this is a worldwide webinar. But it enables you to put your own figures in here for the working days per week, the number of anesthesias per day, etc. So I would put it to you that this is quite a conservative example here. And it really shows here that there is a lost time waiting for anesthesias to work in this person's week of 220 minutes. Now, if you add in the cost of running your office, let's say $750 per hour to run your whole business, this can suddenly mount up. A weekly cost to you by waiting for anesthesias to work is $2,750. A monthly cost is $11,000, and a staggering $132,000 in an average year. So this is a big cost to the office, to the practice, and to the dental business. Behavioral management for the dentist is difficult when you're holding a syringe about 1.5 miles away from the patient. The control you then have over your patient's movement is minimal, and your stance can be seen as quite aggressive to a young patient. This is a moot point. I am of an age where I have started to get nodules in on my tendons, and this is, I am sure, through using my right hand over a career in dentistry. Multiple injections, unless we really don't like our patients, we're not going to give those bilateral blocks because they really won't know where their head's gone. So this requires a second appointment. Running down the surgery, new appointment, it's time and it's costly. And then, of course, we really want to form these relationships with our patients. And if we put our patients off by any of these aforesaid mentioned issues that are problems for the patient, then our retention of our patients is going to be compromised. Stress is something that you cannot underestimate. One of the reasons why I'm sitting before you today is that in 2014, when I discovered the techniques that I will show you in a moment, my stress levels just disappeared. It was quite extraordinary. I started to really enjoy the work I did. And then in this modern era of social media and feedback and reviews, what we don't want is to see 1-star reviews. Pain is often cited as being one of those problems for patients, and this gives us a very bad image. So let's go back to that abstract at the beginning. Anesthesia is critical to the work we do. I would like to now show you new and proven techniques involving electronic delivery of anesthesia, and specifically intraosseous anesthesia, that is going to change your world. So I'd like to introduce you to a family of devices from Dentalhitec in France. And these are electronically controlled dental anesthetic delivery devices. These enable a doctor to provide a completely painless, immediate, deeply profound, and predictable anesthesia with a single injection, the patient having no collateral numbness and no loss of motor function. So let me just let that sink in. We're talking painless. We're talking immediate. We're talking deeply profound. We're talking predictable. You know it's going to work. And the patient is not going to walk away with a numb face. It is a remarkable wow factor for the patients. So let's divide this into two aspects. First of all, there's the electronic delivery. I used to think electronic delivery was for lazy doctors who didn't feel like they wanted to put the effort into using their right thumb, or left if they're left-handed. How wrong was I? Let me just compare here in this animation. This would be an animation showing an infiltration in the soft tissue with a manual syringe. Now, it doesn't matter how slowly you think you're going to be going, you will always go quite fast, and the anesthetic will enter the tissues before the vasoconstrictor has had a chance to shut down those vessels. The significance of this is that you end up with a less concentrated anesthetic effect where you want it, which is where you put the anesthetic, and you end up with a much larger area of collateral numbness. Let's compare that with an electronic delivery. At a very, very slow starting rate of delivery, the vasoconstrictors can now do their job. Shut down the vessels locally so that the remaining bolus of anesthetic you deliver will stay where it's put. And that means that you'll get a much more concentrated effect at the site that you wanted and a vastly reduced area of collateral numbness. So this is something that all of these devices will enable. The true innovation comes with intraosseous anesthesia. And this is what Professor Johan Apps was talking about when he did his study and showed that this is the way to be predictable with your anesthesias. So let's look at what our target is. I would put it to you that if we're treating a tooth, our target is the last point at which the nerves will enter that tooth, at the apex of the tooth. Now, intraosseous anesthesia is not a new concept. Back in 1906, Dr. Nogi in France, he described what he called diploic anesthesia. And that is effectively what he was saying was diploic, like a sandwich, two cortical plates containing a volume of cancellous bone, where the teeth lie and where the nerves lie. And he said in the literature in 1906 that if you fill up that bone, that chamber, that box with anesthetic solution, analgesia, he said, is immediate and absolute. That's where we're heading. So let me introduce QuickSleeper 5. QuickSleeper 5 has been described as the Swiss Army knife of dental anesthesia. This will allow you to deliver all of the traditional techniques with the advantages of the electronic delivery, with the advantages of the special needle that I will show you in a bit, and it will enable you to deliver intraosseous anesthesia in all of your patients. Let's look then at this animation. This animation I will move fairly fast, so I will speak fast. But using that very special Effitec needle, the first stage of 3 is to deliver a few drops at the base of the papilla, if you're going between two teeth, or overlying the point of access to the bone. This provides you with an area of blanching. That means the periosteum beneath it is anesthetized. So when you reorientate that same needle, it will effectively allow you to touch that bone surface with no feeling for the patient. The needle then rotates. It rotates intermittently, controlled by the computer, and it will deliver it very, very gently through the cortical plate and into the cancellous bone. At which point, stage 3 kicks in, which is the delivery of the anesthetic solution into the bone. In so doing, you fill up that chamber. You do exactly what Professor Johan Apps said, and you effectively anesthetize all the nerves within that bone from wherever they are coming. So it will get all of your accessory nerve fibers as well as your main trunks. I made a glib statement there that there is no need for a second injection, but you're only placing a buccal injection here. Why don't you need a second? Well, the answer lies in the fact that the anesthetic solution is inside the bone. Let's take this diagram. We've got a cross section through a section of cortical plate. The pink line there is the periosteum on the external surface of the cortical plate. With a traditional infiltration, we are delivering a bolus of anesthetic external to the cortical plate in the soft tissues. Through the Voltman canals and the Haversian system, this solution will diffuse through the cortical plate into the cancellous bone. So this is in fact ultimately an intraosseous anesthesia, but in the meantime we've got a bolus of anesthetic in the patient's face, causing the numbness and the loss of motor function. Let's compare that then with intraosseous anesthesia. Here we're going to be placing the anesthetic solution inside the bone. We're cutting out the middleman, the soft tissues. You'll still get an opposite direction diffusion out through the cortical plate to anesthetize the periosteum 360 degrees around that bone. It will diffuse out in all directions. And with it, the anesthesia will take effect in the attached gingival tissues. So we're talking about all of the tissues cervical to the mucogingival junction, both lingually, buccally, palatally, labially to that tooth. So you do not need a second injection. You can get straight on with the treatment. A clinical example, extraction of the upper left lateral incisor. 3 stages I reported. The first is your stage 1, the blanching. The periosteum is now anesthetized. Reorientate the needle, make contact with the bone, totally painless, deliver that beautifully through the cortical plate and into the cancellous bone, and the computer then delivers the anesthetic solution. You have control over that. We'll come to that a bit later. Once that is delivered, you remove the device and pick up your forceps. Straight away, immediately, that tooth can be removed. No need for a palatal injection. So I would call that smooth efficiency, and we're talking pretty much 2 minutes or under for the whole thing. And I'm going to tell you, sometimes it can be embarrassingly fast, but incredibly effective, and the patient is absolutely blown away by this. So this is the way to serenity. Let's show a video example. There's no sound with this, so all it is a watch. Lower right mandible. The Effitec needle is brought up at a very shallow angle. You can see the blanching will start to occur with that very, very slow delivery. Once that blanching is residual, the periosteum is anesthetized beneath. That means you can reorientate the needle, same needle, make positive contact with bone, warn the patient there's going to be a little buzz, a little vibration, because that's all they're going to be aware of, and then the needle will rotate. On rotation, it will start to very gently deliver itself through the cortical plate and into the cancellous bone. You can see that as it drops through very nicely there, through the cortical plate and into the bone. The patient feels nothing other than a slight vibration. I know this. I've been using it for so long, but also I've had many of these done to myself as part of my training others. So I have never felt anything more than that little vibration. As soon as that delivery has taken place, which is very steady and controlled completely by the computer, you can withdraw the device and start work straight away. There is a subtle difference between the maxilla and the mandible, and this relates to the blood supply. In the maxilla, there is an omnidirectional or multi-directional blood supply. The significance of that is that at any given site that you choose to deliver the anesthetic in the maxilla, you will get a symmetrical spread of the anesthetic effect distally, mesially, buccally, palatally. This differs slightly and subtly from the mandible. In the mandible, there is a unilateral blood supply running from distal to mesial. So for any given site you choose to deliver the solution, you will get a slight bias of the effect of the anesthesia to the mesial. So the rule is 1 tooth distal, as many teeth mesial as you have delivered solution. You can deliver anesthesia with 1 injection, certainly in the midline, to 8 teeth, including the labial and lingual attached gingival tissues. It is a significant volume. There is also a little paradigm shift here. We take in the mandible, we would never, when treating teeth on the left, we would never deliver anesthetic on the right. We're looking at the nerves, not the blood supply. In the mandibular symphyseal region, for example, you have got no barrier. So if there is indeed an area of pathology and the tooth on the left that you want to treat, or the roots are very close together and there's no good bony access, it doesn't matter. You can deliver the anesthetic on the right, knowing it will diffuse through. So it's volume up on your devices now, because this was a case that I concluded with a film crew in the room. No nerves there, I promise you. So this was a live demonstration of not only the anesthesia, but the treatment itself. Now it's a video, and I'm going to tell you now, that lasts 5 minutes and 16 seconds. I'm not going to show that now. And that 5 minutes and 16 seconds was the time between the initial contact of the needle with the tissue and me having completed the cavity prep, ready for filling. That is an extraordinary saving in time. And the beautiful thing was that and the time saving comes from the fact that as I removed the needle, I popped it down, picked up my air turbine and went straight in. I did not test the tooth to see whether it was numb, because I knew it would be numb. And Christina, you will now hear from her as to what she felt about this. So what did Christina feel?
Honestly, previously when I've had this sort of treatment before, I've had to psych myself up for the needle part. But I didn't honestly feel a thing, slight vibration that lasted no more than 10 seconds, and then straight away into the procedure. And I feel like I've only been here 15 minutes, so that was much better than that previously under previous treatments. I feel like I can go drink hot drinks, I can go straight to work. I don't feel like there's any slurriness in my speech, or I don't feel numb at all. I literally feel as if I've come in, just had a chat with you, and then next thing you know, I've had the filling. I don't even feel I can move my tongue, and there's no sharp bits. I just feel like I can just go back to work now and just carry on the rest of my day not feeling numb.
So that was Christina, and that was her experience. And I can tell you now that that is an experience that is common to all the patients who use this on. And it is lovely to get testimonials, as I will show you at the end of my presentation today. So what can I use this on? Let me tell you something. Since 2014, I have not held a manual syringe in my hand since. Every single anesthesia I have delivered since has been with the QuickSleeper. So I started writing a list some time ago as to what I use this for. And suddenly I realized that's really very silly, because I use it for absolutely everything. There are specific benefits. For any of you that place implants, it is well recognized in posterior mandible that it is a sensible move to keep the anesthetic light, because what you don't want to do, however carefully you have planned an osteotomy in posterior mandible to stay away from the inferior alveolar canal, you want to know if you ever, for any reason, get close to it. The beautiful thing about intraosseous anesthesia is that that inferior alveolar nerve will never be numb, because you're numbing all the other nerves that are involved in the surgery. So the patient will always be able to feel if you are anywhere near the inferior alveolar nerve. So this was certainly my friend and colleague, Santosh Patel, who, with just a single small volume intraosseous anesthesia, completed that treatment extraordinarily quickly. I wanted to leave a mark on the world. This is, by the way, a joke and very tongue-in-cheek, but I've given myself a Prynne classification of implant surgery anesthesia. And sensibly, I've divided this into 3. I've learned most of my things in my world through my own experience and through errors, making errors. I'll always be very transparent. And with class 2, I made an error the first time I did it. But class 1, flapless, straight through, 100% intraosseous anesthesia, single delivery, straight into osteotomies, place of the implant, placement of the healing abutment or the temporary abutment, and that's it. It's as simple as that. It's very quick, very efficient, very effective. Class 2 is where I am going to stay within attached gingival tissues. So I assumed that that would remain completely numb, that the small flap that I made just within attached gingival tissues. I placed my anesthesia, my intraosseous anesthesia. I raised the flap with the incision, no worries whatsoever. I checked the bone, I remodeled the bone there. I did my osteotomy, I placed the implant, I placed the cover screw, and then I went to close within 10 minutes. Picked up the little flap of attached tissue, touched it with the needle, and my patient went, ah, and felt that. And I thought, my goodness, what has happened? Well, on thinking about it, there was never any anesthetic solution in that tissue. It was getting its anesthesia directly from diffusion out through the bone. What had I done? I had removed that contact between that little flap and the bone. So almost instantly, that little flap had lost its anesthesia. So what do I do now? Class 2, I will deliver a stage 1, that's the mucosal anesthesia, both sides, covering both of the flaps, and then I will close. So again, 100% intraosseous anesthesia. I just add an extra stage 1 on the other side. Anywhere, because intraosseous anesthesia will only provide anesthesia to the attached tissues, the moment you start to raise a flap beyond the mucogingival junction, that's when you know and you recognize that you do need a little infiltration in addition. Good. So taking the other two in the family, just mentioning them now, they will both use the Effitec needles, so they will both be completely painless. They will both have a computer-driven delivery of anesthetic. These will provide maximum comfort for all traditional techniques, and they will provide intraosseous anesthesia with children. The SleeperOne, a wired device, the original, and then the much more modern Soan, which doesn't have a cord. It runs on a battery, but will still use the Effitec needle and is much more portable. So for the pediatric protocol, I will just touch on very briefly. For intraosseous anesthesia, it is exactly the same 3 stages as with QuickSleeper, but you don't have any rotational capability. So in the middle there is the manual bone penetration. It just involves firm pressure, and the needle will just drop through the cortical plate. And then the anesthetic delivery is completely like I've reported before, still 3 stages. The cost efficiency here is high in that with Soan and SleeperOne, you have got these clear containers for the cartridge, and they can be used for 50 sterilization cycles, and you'll only ever need 1 cartridge and 1 needle for any one job. So that in dollars again, your total cost per procedure comes around to about 80 cents. So it is a very low cost for running these devices. Unlike with the manual syringe, when you're, as I said a little earlier, you're 1.5 miles away from the patient. With these devices, where you hold them very much like a pen, so you're holding it like a pen, you can use your other fingers to help support your patient. So you get that wonderful bimanual reassurance for your patient, and the fine control, because you're holding the device like a pen, the fine control you have over the needle means that it is an incredibly gentle and controlled procedure. It's very caring. You get a great relationship with your patients by doing this. So I've made much to do today about how this is painless. Let's find out why it is painless, how it is painless. First of all, you've got that very slow initial delivery. You can see in this video that drop, that is as fast as the device, or should I say as slow as the device, will deliver the anesthetic. I would challenge anyone to deliver a consistent manual syringe delivering at that speed. A slightly exaggerated graph shows this manual injection, me on the last patient of the day, wanting to get home and delivering it a little bit too fast, and that can sometimes cause pain for your patient. But if you look at the green trace about to happen, this is how the device will deliver. Very slow at first. That will cover any further delivery of anesthetic with anesthesia locally, and it will then deliver the mother load, the rest of the solution. So to get a good result, we've got this electronic delivery, we've got that very slow delivery, we've got the needle, and we've got a very high precision of control. The support points will, as I said, go away from this hand 1.5 miles away from the patient to provide what we call the circle of safety. Precision pen grip and control. Again, people sometimes look at this and say, well, that's really obtrusive when you have 2 hands around the patient. But I can tell you for a fact that patients are very reassured by this, and I've had many of these done to myself, and you feel very safe. You feel very secure with this level of support. Now, I promised I would show you the needles. The standard needle, shown here, has 3 bevels, and it renders a point, and that sharp point, when looking at it microscopically, just tears the tissue as it enters it. There is no cutting potential on that, it's just sharp and it tears. The Effitec needle differs in that it just has 2 bevels in manufacture. It has 1 long, very shallow bevel, And then in manufacture, the needle is turned the other way up and a little back cut is made. That renders a scalpel. The technique is not to push that needle into the tissue. The technique is to lay that bevel flat on the surface, push down gently as if you're just going to compress the tissue and start the delivery. In so doing, that little scalpel edge has delivered itself submucosal, and the delivery of the anesthetic starts that wonderful whitening, blanching as the anesthetic is delivered submucosal. That is why it stays completely painless. We stay well clear of the periosteum by staying very, very shallow. So the whole thing is very gentle, and this is something that it can be shared with traditional techniques, with these devices, and with intraosseous. So the Effitec needles come in 3 forms. This protocol standard is your white needle. Each of these have the Effitec tip. That is 16 millimeters long. It is a 30 gauge needle, very, very fine. If you look at a patient and they've got a very thick cortical plate, or you're dealing with an extraction site where the healed cortical plate is thicker and more robust, then you can use the yellow needle. The yellow needle is a 16 millimeter 27 gauge needle. That is more robust. That will get through thicker bone if you need to. And then there's, for the pediatrics, for intraligamentary injections, for PDLs, for palatal injections, if you choose to do that, then the ultra short 9 millimeter 30 gauge needle is used. This is the needle that is commonly used for intraosseous anesthesia using Soan and SleeperOne, because it being much shorter, you get much more control over your pressure. So how do we go planning? How do we go about planning this? Now, planning is a combination of radiographic and clinical examination. On a radiograph, these little green spots show clearly where there is bone. And as long as you've got access to a good volume of bone, you know it's going to work beautifully. Radiographs can sometimes be very useful also if you see the red spots here at showing where it's unwise to go because the roots are too close together. You may have a very curled root which stops access to that area. You may have pathology. Does it matter if you have these areas that you can't get to? Absolutely not, because all you do is find the nearest good available bone access, knowing that that solution will now diffuse through to the point where you want to treat. So radiographic assessment is fine, that can give you some artifacts. Here, for example, in this periapical, I would not, looking just at this, want to try and deliver a needle between those 2 molars. However, this is the same patient, and you can see quite clearly there's plenty of room. But here we've got an issue with either curvature of the mandible or angulation of the X-ray. So it's an aberration, it's an artifact. So if you're not quite sure, then the second part of planning will be clinical planning. So here we've got crowded anterior teeth, and if you just went at 90 degrees to a tangent on that arc, the chances are you might hit a root, but you can see that. All you do then is you just re-angle so that you can visibly see you're going between the roots of the teeth, and that makes it all very, very easy. I don't want to make it sound complicated. It's really very straightforward. So what anesthetic products have we got? The protocol standard would be a 4% articaine in 1 in 200,000 epinephrine. That will give a good 30 to 45 minutes of absolute serenity for your patients. If, as I did, you want longer for endodontic treatment, for CAD/CAM work, you can choose a 4% articaine in 1 in 100,000. That is going to extend the length of that appointment beautifully up to, in my experience, 75 minutes. I never, however, went over 60 minutes without just doing a gentle top-up. That is extremely easy to do. If I was doing a planned long appointment, I would deliver the primary anesthesia, and I would always say to the patient, this is going to be a slightly longer appointment, as you know. In about 60 minutes, I'm going to be topping this up. Is that okay? And 100% will turn around and say, yeah, sure, that's fine. Primarily because they had never felt anything on the first one. So they were perfectly happy. Endodontists Trauma surgeons may like a 2% lidocaine in a 1 in 50,000, or as we have here in the UK, a 1 in 80,000 epi. That needs to be done with some caution because that is a powerful vasoconstrictor. So you must just simply make sure that you follow all the protocols and get that tip of the needle and deliver the solution into a good volume of highly vascular bone. Easily done. So a summary of the planning will be this on Stefan's triangle. Ideally, you want to be as close to the tooth you're treating as possible. If you are as close right next to that tooth, you will probably only need a quarter of a cartridge and you've got a 30 to 45 minutes of absolute serenity. Sometimes you can't do that. Sometimes you can't, for all of the reasons I've just said, you have to move away. If you have to move away, you just increase the volume you deliver, knowing that that will diffuse through. And then you've got the control over the longevity of the treatment, how long it's going to last. 1 in 200,000 will get you 30 to 45 minutes, 1 in 100,000 up to 75 minutes, and then an hour and a half for the stronger ones. So I can say now to you that dental equipment in anesthesia has now evolved. We have something there that is going to give us that painless, immediate, deeply profound and predictable anesthesia with a patient that will not leave your office with a numb face or a droopy lip. They can go straight back to work. So they feel no pain. They are happy, calm patients. And those that feared the dentist before, it seems to dissolve away. For the dentist, you've got, for the first time, a predictable treatment on a hot mandibular molar. It's an absolute dream. You've got immediacy of action, so you're not wasting time. You get straight on with it. You can control your appointments so much better. My stress levels just disappeared. There are no postoperative side effects to this technique. The 30 gauge needle is so fine, it just delivers beautifully into the bone. The healing is hardly noticeable. It's very cost efficient as a procedure. The operating costs, as I said earlier, are just 1 cartridge and 1 needle. The appointment optimization. I used to, with my old manual syringe days, if I had a busy day and someone rang up with an emergency, acute pain, I would never want to turn them away. So that what would they do? They'd sit and wait. When you got a chance to see them, you between other patients, you'd get them into the surgery, you'd speak to them, you'd do special tests, you diagnose, you would get consent, and I would deliver an anesthesia and then get them to go and wait outside and hope I could get to them soon. Since 2014, when I took on the QuickSleeper as my primary and only anesthetic tool, I have never sent someone out to wait again, because you can just deal with it there and then. Get all of the diagnosis, the special tests, the consent, deliver the anesthetic, do the emergency treatment, they're gone. The efficiency is extraordinary. And the practice image can be hugely augmented. The patients will tell other patients, they'll bring family to you, they will leave stunning reviews for what you have done for them. So it's all very positive. Now again, if you pop your volumes up, let's listen to Christine. Christine was a patient who she had many inferior alveolar nerve blocks in her time, and this was about 2015. She came along and had a treatment on a lower right mandibular molar, and when she sat up after the intraosseous anesthesia and the procedure, she made a funny little noise, and I said to her, Christine, are you okay? And she said, yeah, I just feel it's I don't know what you've done, it's just I don't feel any different. And I said, stop. I said, if I hold this this phone, will you say that again? And of course, it's a wonderful point to get these testimonies. And so she did. So I'd like you to not only listen to what she says, but also look at her face. I have just done the equivalent of an inferior alveolar nerve block, and she doesn't feel numb, she doesn't look numb, and she functions perfectly normally.
I just had a filling, and Andrew's used the QuickSleeper to numb my tooth, and it just feels fantastic. I can't tell any difference. It feels just the same as when I came in. I couldn't know at all. It's so much better. It's fantastic.
Thank you, Christine.
Thank you, Christine. So this is an amazing testimony you can get from your patients, which you can use in social media, on your websites, and in Christine's case, she comes all around the world with me, and she's very pleased about that. Now, that's from a patient point of view. Armin mentioned a bit earlier that I've been doing a lot of traveling recently, and doctors in the US have just recently got access to these devices. So let's listen to what they think of it.
In my opinion, the numbness that you get from an IO injection is way more profound without all of the collateral numbness of the lip and cheek and tongue.
Yeah, 100%.
I expected a little bit of pain, but there was no pain.
I didn't really have any pain at all. Felt more like a vibration. It felt like somebody was cleaning my teeth really well, like an ultrasonic scaler or something like that. But no, it felt fine.
We gave it a test about less than a minute, 30 seconds later. And it's wild because I don't feel or look as though I had a full block or any sort of anesthesia, but we tested it multiple times and I honestly couldn't feel anything there.
I know that it's better because I have now been using a Soan for the past year, and patients are less afraid of it because it's less intimidating. They are certainly more numb than I was ever getting them with a traditional block. And the fact that I can lay the device down and pick up my handpiece and start working immediately has completely changed the flow and decreased the amount of time the patient spends in the chair, which in the end is financially more beneficial for me and better for the patient.
I love the fact he says, and better from the patient at the end. But so this is from, as it were, the horse's mouth. These are doctors who have really seen the benefits of this. Dentalhitec Academy is here to support you. I like to put this image in because on the left there is Dr. Eric Ledegard, and he was the gentleman who gave me my very first intraosseous anesthesia. I call him my spiritual father, and he calls me his spiritual son. So we are here all around the world to look after you and give you the support that you need. We will support the distribution teams and certainly your team in Croatia, the Nova team, and your hand will be held at each stage when starting to work with this. You won't need that hand for long. You will sail, you will fly with this, and it will be to the betterment of your patients, to yourselves, and to your dental businesses. Now, you're very welcome to get in touch with me direct. I am available. I will give you guidance as to what information I need. If you have used the device and you're not quite sure why something happened, as I say, I learned most of my stuff through making mistakes myself. So there is no shame in that. And you're very welcome to get in touch with, of course, Dentalhitec Direct and Nova team in Croatia, or your own local distributors. So I'm going to hand you back now to Armin, who will enable you to ask any questions.
Yes, so let me make it a bit more lighter here. Yes, Andrew, thank you so much for all this information, for all this good overview, and also the testimonies. I think that really the feedback from patients themselves, from dentists that started using it, are really, really powerful. We had actually quite some questions already. I postponed the chat a little bit, that you will personally answer it at the end. So now we are at this point. So I will read them for you, and then if there are new ones coming, let us know. I also summarize it a bit. The first question was, should we inject when it is drilling inside? I guess the question is, should we inject while drilling with the QuickSleeper?
That is a very logical question. One of the things that is beautiful about these systems is that you don't have to think. Once you get those 3-stage protocols right, just by activating the device in each of those stages, the device will do it for you. So you're right, absolutely spot on. While the device is drilling, it is constantly delivering very slowly some solution through the needle. This is for several reasons. It makes sure that this keeps the needle beautifully cool, and lots of studies have shown that there is no increase in temperature of the bone around this, partly because of that and the smoothness of the needles, but also as you are delivering a tube through bone, you can imagine the potential for bone fragments to enter the lumen. This makes sure that it keeps them clear. So yes, it does. You don't actively do it yourself. The device will do it for you. Great question.
Okay, then we have a short question, but does it work for root canal treatment?
Endodontists absolutely love it. Remember this, my slide showing what it works for. I haven't picked up a manual syringe. It works for everywhere and anything that you need anesthesia for in the oral cavity.
Okay, perfect. Then we have isn't the bone burning because of the rotation? Was one of the questions.
Yeah, it's a good question. It's a logical question, and I think I've answered that in the previous answer in saying that it is a very, very smooth-sided steel. And there is studies have shown, you know, this is not just guessing whether there is any increase in bone temperature. There is no increase in bone temperature. The whole thing is very gentle. The needle is actually rotating intermittently at a speed of 15,000 RPM. So it's not high speed, but it's enough to give a little vibration. No increase in temperature, no.
Okay, perfect. Then one question was, do we need specific needles and cupula for QuickSleeper 5?
Absolutely. These are the Effitech needles I've described. The range of needles, the 3 needles, will cover all of your needs. I'm going to say it now. It's slightly off this specific question, and forgive that, but if you are using QuickSleeper and you want to give an inferior alveolar nerve block, people will sometimes ask, and this could be a question coming up, I mean, I'm sorry if I'm jumping in early, but can you aspirate to check that you're not intravascular? If you're using the standard rotary container, then you're not going to be able to see that. So each of the QuickSleepers comes with its own clear container as well. It has a setting on it for infiltrations, which does not allow any rotation. So you can give an infiltration or a block with this QuickSleeper device, and you choose then to use a clear container. Now that means that you can then aspirate. Which when you press the aspiration button and it's all controlled on the foot, there are no clinical controls on the device itself, which allows you to focus absolutely on your patient. By pressing the aspirator pedal, it just retracts the plunger ever so slightly and slowly, and that will allow you to see if you are intravascular. So yes, if you did a block, you could easily pop one of your own longer needles on if you choose to do so. I will put my hand up and say I have not performed an inferior alveolar nerve block since I received that device.
Okay, thank you for that answer. Next one is also quite a good one, quite an interesting one. I think that's a lot of people wondering that. What are the chances of making a perforation in the root?
Okay, again, a very logical question. 0. Absolutely 0. The fine, delicate and precise Effitech needle is able to get through bone with the protocol care and the rotations, but it will never, ever be able to get through dentine of a root. It is too dense. A patient will not allow you to get anywhere near the root anyway. I've said to you that this is a completely painless experience for the patient. One of my many little rules is that if at any point the patient is aware of something other than the vibration you've told them is going to happen, then stop, because something is wrong. This is a painless experience for the patient. If, for example, you've got your angle very slightly wrong and you are heading toward the periodontal ligament of a root, then the patient will start to be aware of it. Now, it's not pain, it's just an awareness that there's a slight discomfort there. That is a sign that it's not 100% right. Under those circumstances, just withdraw the device, have a look, see where your angulation was slightly incorrect, change the needle and go in at a better angle. While you are drilling the needle into the bone, there is at that point no anesthetic effect on that area other than the periosteum on the surface. That means that the periodontal ligament is still vital and well. It's a safety feature. Your patient will be able to tell you if you're going anywhere, if your angulation is wrong in any way. Good question.
Okay. Thank you for that answer. I have another specific one. What's the reason for intramuscular injection failure?
What is the reason for intramuscular injection failure?
Yes, that is the question. I'm not quite sure what the reference is here, but yeah, maybe.
I am not sure I fully understand the angle of that question. However, what I will say is that there are many reasons why traditional techniques will fail. We've talked about the accessory innervation through the nutrient canals or the accessory canals, blood supplies in the mandible. Failure in intramuscular, I'm not sure I understand that question specifically. You're very welcome to perhaps elaborate on that in the questions, and Armin can come back to it. But any tissue you inject anesthesia into will be anesthetized locally, but I'm not sure of the relevance of that, I'll be honest.
Yes, so if you want, that was from Dr. Tariq Mostafa. Please specify if you want more, or if you feel it answered, that is also fine. The next question was, with the mucosa, we would know the amount of anesthesia we are infiltrating due to the change of color, I guess the whitening. But with bone, is there a way for us to determine the limit for a single point of injection?
Very good. I think you're right in that we have a visual indicator, don't we, as to when we have completed stage 1, and that is your choice as a doctor. So when you have that residual blanching, you're right. You know that periosteum is anesthetized, you reorientate and deliver. Now, the volume that you want to deliver will be determined by a couple of factors. Firstly, how many teeth you want to anesthetize. Clearly, the more teeth you want to anesthetize, and you can do quadrant dentistry here, the more volume you need. The other factor is the size of your patient. I have known patients who are big people with big jaws. Deliver a cartridge into that jaw and it's not going to anesthetize, spread and to anesthetize as many teeth as if the next patient you deliver a full cartridge on is a very small person, a child, just a very thin adult. Clearly, the volume of bone in that case is going to be smaller, which means any given volume you introduce is going to diffuse further. So it is just experience. I would say to you that if you are right next to the tooth you wanted to treat, it doesn't matter if they're a really big patient or a really small patient, a quarter of a cartridge is going to work very well. It's when you're treating a number of teeth, you need to make sure you are delivering enough volume. And it comes with experience that there are other factors, such as in the mandible, the drift to the mesial. The blood supply will take that anesthetic to the mesial. You want to make sure that you are allowing for that when planning your anesthesia, and that you are not going to try and treat 2 teeth behind it. because it's not going to have diffused that far. Another reason for actively delivering a full cartridge is if the tooth is a hot tooth. Don't mess around. Give yourself the best chance of a great result. So if it's a really hot tooth, I will deliver a full cartridge where the bone volume is appropriate.
Okay, thank you for that answer too. I have now the next question. I might answer that, but just so we know, can we get a brief rerun of the slides? We were waiting on the Soho meeting app and had no idea the webinar was on Microsoft Teams. So for this one, it was quite recently organized. So we had two platforms. There was a mail with a link to this webinar, but we didn't actually do it with the Soho platform. So for everyone who couldn't attend now or who came a bit later, we will make a replay available for a certain amount of time. So after this, if you were signed up with Soho, we will make this review available and you can look through. I think that makes more sense, but we'll skip this answer for now. And yeah, sorry for the double platform confusion. I know plenty of you made it, but I could also imagine a lot of people got stuck on the other platform. So yeah, we will be improving on that and you will get a review or replay afterwards. I have one more or two more clinical questions for now. It was, can the needle break inside the bone?
Again, an extremely logical question. Inside the bone, no. We are talking about a protocol that keeps the important thing is to keep the device at a consistent angle to your patient. Needles can separate, and they tend to happen if the device goes offline relative to the patient while rotating. I will remain transparent with you and say that in all of my many years with this device, I have separated 6 needles. No patient ever knew that had happened. No harm has ever been done to any of my patients with this device. It's an extraordinarily safe device. If the needle separates, it separates up by the hub. The protocol is never to deliver that needle right down to the hub, and that needle is also going nowhere. As soon as it separates, that needle is firmly held by the bone. It's not going to migrate like the very famous and well recognized papers are showing separation of a needle are doing in soft tissue with an inferior alveolar nerve block, where ultimately the needle had to be surgically removed from the patient's neck. That is not the case. It's absolutely safe. I could, in theory, with my fingers, pick that separated needle and remove it from the bone. There is no engagement. It will just come straight out. Of course, I don't teach that, cross-infection issues. So I would, in those early days, recognize the separation, pop the device down, say, Becky, could I have my mosquito forceps, please? She'd pass me my little tweezers and I would pick that out, click, pop it down. Becky, there's a sharp on the top there. In the meantime, she's gone around the chair, changed the needle. I probably never even moved my left hand. So the patient has never known anything is out of sequence, and I pick up the device with the new needle and do it again, but this time make sure I've got good control. On that subject, if you'll forgive me, patient movement, fascinating. I have a number of patients with an advanced Parkinsonian movement, and you may look at them as they come into the room and their head is moving constantly, and you're thinking, how am I going to do anything precise here? Well, the answer is very straightforward. With these multiple bilateral contact points, as soon as you have locked that device onto the patient's head, yes, the device may be moving with you, but it's not moving relative to the patient. The only thing that's absolutely shattered at the end of those appointments are my eyes, which have been following it round, but absolute stability.
Okay, great. I think we also know are safe now with the needle situation. I have one more question. I don't know if you have the QuickSleeper set up ready, Andrew, but somebody was interested in, can we see how we set up the carpal and needles inside the QuickSleeper 5?
Yes. Absolutely right. So
Okay.
when the device is in standby mode, it is just sitting there. It can sit there all day just like that. The first thing I will always train people to do, because the plunger has got a lot of little sensors in it and that's the delicate part of the device. It's a high technology device. I will always encourage people just to press the one reset control on the device there, the little 0. You can see that the lights will flash and the plunger resets itself. The control box will reset itself. You then take your rotary container, which is the only bit of the device that needs any maintenance, and that is a little drop of oil on the bearing after each of the procedures. You take that sterilized device, you pop in a cartridge, and you pop it straight in there. Now that cartridge is completely captive. You then bring that up to the head of the QuickSleeper, and then that is now loaded. You take a needle of your choice, you pop it on, so now it's held with the bung of the cartridge, and supporting that gently, you press and hold the lock on button here. And as you press it, the motor will load the needle on. So now that needle is firm. That is now loaded, that needle. It's now ready to operate. And by loading the needle, you can see now that it is changed to IO setting, which will take you, the computer now knows you're going to go through that 3-stage process. Stage 1, mucosal anesthesia. Stage 2, the rotation. And stage 3, the delivery. Now you don't even need to touch this. All of the controls are actually on a wireless and batteryless foot pedal. This is light as a feather. There's no battery or major electronics within it, and it has various controls. It has controls over the mode. You can change that between the intraosseous. You can change it to a low, which is an intraosseous setting, which just it's designed for children or very delicate adults, where it just slows it even more, or high, which is the setting where there is no rotation, and that will be a much faster delivery after that initial slow vasoconstrictor optimizing delivery for infiltrations or blocks. The main delivery will come on the grey pedal here, and the rotation is controlled by the orange pedal. So once it's all set up ready, your foot will initially, once your needle is against the tissue for stage 1, you just press the grey pedal and it will immediately start that very slow delivery. Once you have reorientated and made contact with the bone, you can press the orange pedal. There is a beep. 2 seconds later, the rotation will start. When you've gone deep enough, you just go straight onto the grey again. So it's a very quick, this loading will all happen easily before your patient enters the room or during the patient entering the room. This is always tucked away under a chair for the patient's support team to sit in. And so it's never obtrusive. The last thing I wanted was another foot pedal. So that just tucks away. It's very, very light and easy to manipulate. So at the end of that appointment, when you're all finished, you just retract the plunger. And when the plunger is fully retracted, you just take the device, press the unlock button on the handpiece, and the motor will just pop the needle off. That can now go into sharps. The control box comes off. The rotary container comes off. You can remove the cartridge. That now will have a little drop of oil in your sterilization system, and then that is bagged and put straight through the autoclave. The handpiece itself is then just wiped down with a cavi wipe or similar, and that's it. So it's very easy to set up, use, and dismantle. I always encourage it to be installed on your chair. I use it every time I want to use an anesthesia, so it's there right next to my handpieces on the proprietary holder that comes with it.
Okay, thank you so much for the demonstration. So now we really saw it in person how it's built up. I have one question that came even twice, almost at the same time. So I think it is a very curious question. It was, can we use the QuickSleeper intraosseous anesthesia? Can we use it in inflamed area? And also this follow-up question was with affected area with different pH.
Okay, yeah, absolutely. Now, some of the indications for intraosseous anesthesia or using the QuickSleeper in traditional techniques is no different from traditional techniques. So your contraindications are the same. We're never going to put a needle and deliver it into an area of infection or disseminated bacterial activity. It's easy to manage with QuickSleeper because we know it's going to diffuse across, so we just find the nearest space that is in healthy bone. So can I put that into inflamed tissue? Yes, I could, as long as I'm happy that that is not infected tissue. So it's exactly the same as with traditional techniques. The contraindications are no different.
Okay, thank you so much. I think that is well answered. I have one question, but that answered it in the question a bit. Can I perform intraosseous anesthesia with SleeperOne or only with QuickSleeper? But their device doesn't have the rotation.
Yep. The answer is yes, of course you can, as long as you can manually penetrate the cortical plate with the needle. That is the limit. Now, people often ask, is there an age where patients will graduate from Soan to QuickSleeper? And the answer is no, there is no age. We normally say about 12 to 14, but it's pretty meaningless because you could get an 8-year-old linebacker come in and their bone is so thick you can't get through it. The next patient may be a 17-year-old, very thin waif of a person who Soan will just drop in. So there's no age as such. QuickSleeper is your Swiss Army knife of dental anesthesias. That will do everyone where it's appropriate. The Soan and the SleeperOne will be limited by the confidence you have of getting your ultra short green needle through that patient's cortical plate. Remember that all these devices will do traditional anesthesias with great skill. So there is no harm in trying to get intraosseous because we know that's going to be a great advantage for the patient. But if that fails, it doesn't mean, oh my goodness, I can't do this now, or I've got to now pick up my manual syringe. Not a problem. You just give a traditional anesthesia. So it keeps you very flexible and versatile.
I think this was all the questions for now.
Okay, thank you very much, Armin.
I think, yeah, from my side, there's a bit noise here, but I would say thank you everyone for being around, for joining us. As I said, the replay will be available to everyone who joined and for those who didn't make it today, and also for those who still have questions open. And yeah, Andrew, thank you so much for your time, and especially with that less sleep, with all the travel, to still joining us here for this webinar. And yeah, I would say also thank you to Novi team for initiating this, for getting us motivated to start this for the Croatian market, but also for the whole Europe and the world market. So I would say it's a good time. We are well in time. So if there's no more questions, I would say we end it here. If you are curious about QuickSleeper, about gathering one for the Croatian team, they will be getting a personal offer from Novi team. For the others, please write us if you're curious, and we will also make you an offer in Europe or in the country where we are available. Then we will see how we can get the device to you if it's possible. And yeah, thank you so much to everyone from my side, and I would say have a nice evening, and yeah, I hope to hear from everyone soon.
Thank you, Armin, very much indeed.